So my name is Sivan. I am a member of Medicare for All Connecticut. We are a grassroots volunteer-run organization advocating for Medicare for all on the local, state, and national level. We believe in people over profits, that healthcare is a human right, and that health should never be traded on the stock market, or that your health or anybody's health should be traded on the stock exchange or in the hands of anyone but you and your chosen medical professional. We as an organization have written statewide legislation. We've passed several town resolutions, as well as working on several more in favor of Medicare for all, and we have endorsed candidates who support our vision of a universal single payer system in which transparency, public accountability, and a more equitable approach to healthcare is possible. If you too believe the same, please join our movement by subscribing to our newsletter, following us on social media, joining one of our committees and working groups, we have several, and donating to our cause. You can check out our website for a ton of articles and resources on single payer, our upcoming events, any actions that we're currently taking that you can take now, and just other ways that you can get involved. So I'll include all those here in the chat now. And please, we'll also include all of our links and presentation information and images in follow-ups. So don't need to worry, if you want to get anything, we will send it along. We are actually also, as an organization, supporting the Husky for Immigrants campaign, led by the group Husky for Immigrants. This campaign calls on Connecticut legislators to expand Husky benefits to undocumented immigrants in Connecticut. As we all know, COVID doesn't care about your immigration status and infects us all. If a person, no matter their status, can't seek care, that puts us all at risk again, and I don't think anybody wants for that to happen. Successfully last year, the General Assembly passed legislation extending coverage to undocumented immigrants who are pregnant and undocumented children aged 0 to 8 years old. But if you, for instance, happen to break your arm while you're playing on your 9th birthday, you're out of luck. So this campaign is carrying on from that last one from last year, to extend Husky coverage to all undocumented immigrants, regardless of their age. So if you would please take the time now to, I'll put the link here. It's the H for I campaign petition, to please sign that petition now. We'll also include that again at another time, but this will send a message to the Connecticut legislature that all people, regardless of their status, deserve health care. It's cheaper for us in the long run because they're not using emergency services, for instance. So it's all around good stuff. And I'll pass it over now to my dear friend, Dr. Justin Paglino, who will introduce us to PNHP, who we're proudly partnering with on this meeting.
Thank you, Sivan. Yes, I'm Justin Paglino. I live in Guilford. I'm a member of PNHP Connecticut. I was also a candidate for Congress in 2020 and will be again this year, running on a Medicare for All platform. But that's beside the point of this meeting. I'm here as a representative of PNHP Connecticut. PNHP, Physicians for National Health Program. We're an advocacy organization of over 20,000 American physicians, medical students, health professionals that supports the Universal Comprehensive Single Payer National Health Insurance Program, co-founded in 1987. And the organization does a lot of work to try and educate physicians, other health professionals about the benefits of a single payer system, including lower cost and better coverage. We also contribute to peer-reviewed medical journals, and some members appear regularly on national television programs and advocate for a single payer system. So tonight we have a speaker from our National Speakers Bureau, Dr. Judy Alpert. Judith Albert, who is a retired physician in Pittsburgh, Pennsylvania. She received her medical degree from the University of Cincinnati, completed residency in OBGYN at the University of Pittsburgh, and fellowship in reproductive endocrinology at the University of Pennsylvania. She practiced in academic and private practice settings for over 30 years in Philadelphia and Pittsburgh. She joined PNHP in 2016 and has been active in her local chapter. She was elected to the National Board of Directors in August of 2021. So, Dr. Albert, welcome and thank you. Thank you for coming.
Well, thank you for having me. It's really an honor to be able to talk to some people outside of my own region. I've been doing a lot of presentations in Pennsylvania to candidates for congressional seats and Senate seats, and that's been pretty interesting. So I'm happy to be able to branch out and talk to another like-minded group. So I do have a PowerPoint that I'm going to share, and I was asked to talk about this threat to Medicare and a threat to single payer. Of course, that is called direct contracting entities. And I'm curious as to whether many people in this group are familiar with direct contracting and the campaign that's just been going on for about 9 months against it. So I don't know, maybe you can raise your hand. Some people looks like they are. So it's complicated, but I think, you know, what we're seeing now is after some dedicated pushing against the CMMI, the Center for Medicare and Medicaid Innovation, that we are seeing that advocates for direct contracting are pushing back against the notion that there's anything out of sorts with it, which is probably the best indication that we're getting somewhere. And you know, how it all happened was last spring, we became aware of these new entities called direct contracting, and there had been a very small number of members of Congress who signed a letter in opposition to it. It was actually started by the Trump administration, but surprisingly, Biden has kept it going. And as we started looking into it, a group of us in PNHP became very alarmed, and we did put together a webinar in September where we had, I think, 600 attendees, and it did seem to strike a note of alarm in a lot of people, and then we sort of went from there. So I'm going to try sharing my screen.
I did make you a co-host, so let me know if you need.
Oh, it looks like I can.
Fantastic.
And all right, so are you guys able to see?
Yes, it looks great.
Yes. Okay. So I also have to give credit to these slides to a fellow PNHP board member named Ed Weisbart, who is the master of creating slide sets. A lot of them are on the PNHP website. If you remember, you have access to use them, which is very nice. What we're starting to talk about is how direct contracting is a threat to Medicare as we know it. But you know, perhaps even more importantly, the more corporate entities become involved in our healthcare, as particularly the one area of healthcare that was publicly funded, which is traditional Medicare, the more difficult it's going to be to ever get a single payer movement going. And so I'm going to try to lay out how this works. As I mentioned, it's somewhat complicated, and there's a certain amount of overlap with Medicare Advantage, although they are not one and the same thing. But if you understand Medicare Advantage, it will help you understand direct contracting somewhat. So the way that Medicare is supposed to work is we have traditional Medicare, we have providers, physicians, hospitals, ACOs, et cetera, who are all included, and very few physician providers don't participate in Medicare. I mean, pediatricians probably are less likely to because it's mostly the aging population, but Medicare does include some other chronic disease states. And so the Medicare managed administrators, meaning CMS, the Center for Medicare Services, would be responsible for paying the providers for the care in a fee-for-service pattern that they provide to the beneficiaries. Unfortunately, when Medicare was created in 1965, it really wasn't something that had 100% support amongst the legislature. And so there were a number of loopholes left, the obvious ones being dental care, hearing aid, vision, long-term care that aren't included in traditional Medicare. And there is some beneficiary responsibilities so that most people that sign up for traditional Medicare, if they can afford it, will also have to purchase a Medigap policy. And currently those Medigap policies are administered by private insurance companies, but they do work in a fee-for-service way, similar to the way most insurance plans work for employee-sponsored health care. But around 1972, as a result of efforts to try to bring down the costs in medicine, and in particular, a small group of people who began to beat the drum against fee-for-service and suggested that the reason why healthcare expenditures were so high in this country had to do with the fact that we used a fee-for-service system that allowed physicians to do more procedures than were needed and allowed people to access more care than they needed. So actually, without any evidence that the reason healthcare costs were so high was because of overutilization, they came up with the original principle of health maintenance organizations, so that they started allowing private insurance to administer the risk of providing health care. And basically what that did was start the gatekeeping that we're all familiar with, because certainly the HMO model filtered down into employee-sponsored insurance as well. But this was the beginning of Medicare Advantage in the 1970s. It wasn't called that yet. It wasn't called Medicare Advantage until the 80s. But you know, we'll see in some of the next slides that it has grown into a bit of a behemoth, and probably some of you are aware of the fact that the Centers for Medicare Services spends more paying out to Medicare Advantage than they do with traditional Medicare. So now what happens is you have a choice when you reach 65 between choosing traditional Medicare and hopefully a Medigap policy, or you can choose a Medicare Advantage plan, which is a narrow network similar to an HMO, where you will be restricted to a certain number of providers that are usually geographically based in your own geographical area. So for instance, if you did travel outside of your state, you may very well not be able to access a care provider in another location in the United States, which for retired people, you know, can be an issue. They may be likely to travel certain places. And more importantly is the infrastructure that Medicare Advantage insurance providers, insurance companies use to reach seniors with massive advertising campaigns. They reach out to groups of seniors and they have figured out a way to recruit the healthiest of seniors, which enhances their risk pool. And because it's a capitated system, if they have healthier people and they can restrict their passages throughout the healthcare system in their region by using only narrow networks, this allows them to be paid the capitated fees from Medicare, which is our taxpayer dollars that keep the fund going, to care for a certain group of individuals on a per member per month basis. And if that member doesn't use all of the fees that Medicare paid to insure them through Medicare Advantage, then the insurance company gets to keep the remainder. So you can imagine that this provides a perverse incentive to deny care. And so I think a lot of people are familiar with this, and whether they're in Medicare Advantage or in traditional insurance through their employer. So now what we're seeing is this new thing that the Trump administration actually dreamed up, that's called direct contracting entities. And that is a situation where CMMI is allowing various corporate structures and also provider owned, meaning owned by a group of physicians or clinic or hospitals, which are usually accountable care organizations, to enter into these risk-bearing middlemen relationships for the population of beneficiaries who actually chose traditional Medicare. And most people who choose traditional Medicare do so because they don't want to be subjected to a narrow network. They want to be able to keep their physician, and they understand that Medicare Advantage has some disadvantages. So it's difficult to understand exactly how these direct contracting entities are going to work because they've just started. And there are currently 53 or 54 of them. And out of those, 28 are private equity venture capital firms. So I think probably you can put 2 and 2 together and figure out that private equity venture capital isn't necessarily a healthcare specialty. And 6 of the 53 are large health insurance companies like Humana, United Healthcare, that are already providing Medicare Advantage plans. So one of the things that we are seeing is the increase in subscribers to Medicare Advantage. And we certainly understand why that's happening, because the premiums for Medicare Advantage are exceedingly lower than they are for Medicare Part B, to the point that sometimes there are 0 premiums. And in addition to that, beneficiaries are offered other services like a gym membership or vision and dental care, which usually turns out to be less than comprehensive. And so the number of enrollees in Medicare Advantage has dramatically increased over the past 6 years. And then if you compare what's happening in traditional Medicare, it's basically staying the same, so that now the proportion of beneficiaries enrolled in traditional Medicare is roughly 54%, and the remainder are in Medicare Advantage. And Medicare Advantage insurance companies have been reaping the benefits of having a larger group of lives that they are insuring through this capitated measure. And also they're reaping the benefits from the fact that even though CMMI and the Medicare Medipac is supposed to be keeping track of the expenditures, what we're seeing is that CMS and the Medicare Fund is paying the Medicare Advantage companies in excess of billions compared to what they would be paying for traditional Medicare. So it stands to reason that somebody had an idea that the remainder of the beneficiaries that amount to about 30 million people who are in traditional Medicare, if they could get them into a middleman Medicare Advantage-like system, they might be able to grab even more profits. So how did this happen? Well, under the Trump administration, DCEs were started, and yet it goes back farther than that, because the Center for Medicare and Medicaid Innovation was actually created under Section 3021 of the Affordable Care Act under Obama. And the purpose of this organization was to try to, quote, overcome anti-reform inertia. And their task was to reduce spending without decreasing quality, or improving quality without increasing spending. And they weren't allowed to deny or limit coverage or the provision of benefits. They can run pilots, and they have run many pilots since the ACA was created and CMMI was created. But there's a great deal, there is a great deal of lack of transparency as to how these pilots have performed regarding whether they do reduce spending or whether they do improve quality of medical care. And in fact, only 4 of their pilots have been maintained. And theoretically, they say that they've been shown to meet their criteria, but it's very difficult to find the evidence for that. And then, you know, the other issue is that if CMMI decides that one of these pilots is the one that has done everything that they wanted to, it can be widely applied across all of Medicare, traditional Medicare, if HHS believes that it has done what it's supposed to do. And furthermore, there's no oversight by Congress to roll out these large innovations that they've been running on small pilot areas. So it does rankle people that are interested in healthcare justice to know that our democratic system doesn't seem to have the ability to curb these systems and keep a watch over the middlemen that are profiting over our health issues. So yeah, some innovations are better than others, but they rarely have been able to show that the tweaks that they make in terms of adding new middlemen, doing different issues with risk and capitation have really made the difference that they say that they would. So the Trump administration came up with two main models. The first one was called geographic direct contracting. And with geographic or geo model, all the traditional Medicare members, again, these are people who had signed up on purpose to be in traditional Medicare in specific reasons that were 10 or 11 major urban areas in the United States that were originally assigned to the geo model. All the traditional Medicare members in that region would be aligned or assigned to that region's direct contracting entity, which could be a United Healthcare, or it could be some kind of private equity firm that's running a group of clinicians and trying to become the middleman in between Medicare and the patient. And fortunately, because of a great deal of pushback once Biden came into office, this geo model was suspended. But it wasn't completely disabled or stopped, and it could be reactivated at the discretion of the executive branch, although we're not aware that that's in the plan right now. So the other direct contracting method is called global and professional direct contracting. And in this setup, medical claims data are used to identify the primary care program and automatically align the member with that PCP's DCE. So PCP usually means primary care physician, but sometimes these are primary care groups like ACOs. And so a traditional Medicare beneficiary would likely not know that their physician had become aligned with a direct contracting entity, because it's not anything that gets publicized. And they might get a letter, and we've seen some of the letters that the direct contracting entity sends to the Medicare beneficiaries, and they they say in very vague wording that, you know, your doctor has hired, one of the big ones is called Clover Health. Your doctor has decided to work with Clover Health to improve your coordination of care. And it's a lot of vague language about how this DCE, that they don't call it a DCE, they just call them by their name, saying this is going to help you coordinate care and get better health care. And so if the beneficiary does not want to be in that sort of arrangement with their physician, they don't really, they can get out of the direct contracting entity, but they would have to change to a different physician because their physician has now been sucked into this direct contracting entity. And presumably this entity will start to work like a narrow network. But, you know, again, we don't have the evidence to support that because they've just started working these DCEs. So there's no real data. But the question is, what do you need a middleman for to, you know, administer the healthcare that the primary care doctor is doing already on their own? So back to the motivation to create direct contracting. So it's important to understand what it is about Medicare Advantage that has generated such enormous profits for insurance companies. And it has to do with something called risk scores. So risk scores are what drive Medicare Advantage reimbursements. And they originally were created to try and help Medicare and CMS predict by, you know, creating a grading system amongst their beneficiaries of the severity of their various conditions, so that perhaps CMS could plan on, you know, how much they're going to be outlaying for the care in under traditional Medicare of these beneficiaries who had various conditions. But now they are starting to be used for a completely different reason. And so this slide is going to demonstrate how risk scores might be generated. So the first example is kind of a very baseline healthy 76-year-old patient. So based on their age, they have a risk score of 0.45, which is quite low. They're totally healthy, so there are no other codes that can be generated for this particular person. And under a situation like this, CMS would pay Medicare Advantage their capitated fee of $4,000, so $4,000 per member per month or per year. Sorry. If you had a patient who had the same age, but also some mild conditions, as you might expect for a 76-year-old, their list of the HCC codes is going to start increasing. So they have type 1 diabetes, they have congestive heart failure, and the combination of congestive heart failure and diabetes gets an additional score. And at the end of their tally, they Medicare Advantage is going to get a $9,000 capitated fee. But what can happen is the coding can be maximized, and there are various ways that this can be maximized. In fact, Medicare Advantage insurance companies are currently allowed to visit their beneficiaries in their homes. A nurse could visit a beneficiary and take a history from them. The nurse would be employed by the insurance company, and as a result of interviewing a patient, they are able to increase the complexity of the various codes, specifically so that Medicare Advantage can get a higher capitated fee for a much elevated and inflated risk score. And it's, you know, in certain cases, the risk scores can be accurate, but there's so much room for playing this system because of the various complexities with diagnosis codes and how that's being manipulated, that, you know, here now you've got nearly a fourfold increase in the capitated fee that this patient has because they added diabetes with retinopathy. They, you know, added COPD, you know, they added an ulcer, and this may be because the patient said, you know, they have heartburn or various things like that. So this is the reason why Medicare Advantage insurance companies have been able to generate such high profits. So what we're concerned about in PNHP is ultimately we're single payer advocates, and we're not in this fight just because we think direct contracting is a big problem. What we're in the fight for is the more that our healthcare, particularly our most beloved and most successful publicly funded healthcare program, which would be traditional Medicare, has been co-opted by corporatization. Some people would call it privatization, but it's really a corporate takeover of the way that healthcare is being delivered, and it's run by the middlemen. So the Center for Medicare and Medicaid Innovation has actually stated that their objective is to drive accountable care, and that all Medicare beneficiaries with Part A and Part B will be in some sort of care relationship with accountability for quality and total cost of care by 2030. And those words are not very revealing, but basically what it means is that a middleman will be in between the patient and their physician, and they will be responsible for deciding what gets paid for, and for determining what are the measures of quality that they will accept, and that is going to lead to a situation where every Medicare, and presumably also it's happening in Medicaid, beneficiary will be run by a corporate middleman. So we believe that direct contracting is a dangerously flawed model that radically transforms Medicare. As I mentioned before, not only are there large health insurance giants who have been accepted as direct contracting entities, there are also 28 private equity and venture capital firms. And I think it's obvious to most people the reason why those entities exist is to turn a profit. So it radically transforms traditional Medicare, and it does so against the wishes of the beneficiaries who signed up for traditional Medicare. It undermines the senior's choice in that way. It incentivizes harmful restrictions on patient care because that's what capitation does. It potentially can incentivize fraudulent diagnostic coding. And it threatens to bankrupt Medicare, because if CMS continues to pay Medicare Advantage more than it's paying the traditional Medicare because of these capitation schemes, that will deplete the Medicare fund quicker. Finally, it avoids Congress undermining the democratic process, because should there be one of these DCE pilots that CMMI decides is the one, the way that their charter is written, it suggests that through HHS, they can then institute that direct contracting entity throughout the whole traditional Medicare population. So we have been somewhat successful at getting in contact with Congress people. And what we've done, so in the end of November, maybe November 30th or December 1st, I can't remember which, a group of physicians, including myself, went to Washington. By that point, we had collected, I think, about 13,000 signatures as a result of the webinar that we did in September, and also Public Citizen had their own petition. And the petition demanded that they that HHS end the pilot program, and it was directed towards Secretary Becerra. So we wanted them to immediately stop enrolling seniors, not accept any more DCE applicants, and not allow any of the current DCEs to go live next year, which is this year. So the slide was made just towards the end of 2021. Better still, just stop the entire program while it's still a pilot. So, we also had a letter that was composed by Representative Jayapal, and we worked very closely with her staffer. Her staffer was previously in a SNAP chapter. She has a PhD in healthcare policy, and she's been very instrumental in helping guide Representative Jayapal about DCE opposition. So that letter, which went out on January 5th, was able to gain 54 signatories from Congress. Interestingly, not all of the signatories of Representative Jayapal's single payer bill signed on. We're interested in holding hearings. We've been told that that's probably quite unlikely by the various congresspeople that we met with. We were also interested in getting them to pass legislation to require congressional oversight of CMMI. So this is a copy of the original letter, which was written in May of 2021. The date's wrong. They put the wrong date on it for some reason. It was written to Becerra. He obviously wasn't secretary in 2020. And so it was written by Mark Pocan and signed by Representatives Pascal Doggett and Katie Porter, all of whom have been single payer supporters. And so that was kind of the first attempt to gain some support in Congress. So in addition to the letter to Becerra, as I mentioned, we presented a petition with 13,000 signatures, and I think 1,500 to 2,000 of them were physicians. And just last Wednesday, a Republican member of the Senate Finance Committee had asked to have hearings on the financing of Medicare, and Senator Warren is the chairwoman of that committee. And she, having heard about our pressure on Congress, reached out to PNHP and asked if we could provide a representative to testify. Of course, Dr. Rogers stepped up to do that, and her testimony on the subject of DCEs was recorded last week, and Senator Warren used a lot of PNHP's information in her questioning, and presented a very strong case for removing DCEs from CMMI. So that's something that shows, also that we've made some sort of inroads. We met on a Zoom call with Elizabeth Fowler and an attorney, name I think is Jennifer Goldstein, I can't remember exactly, and challenged them about, why do they need another middleman, and basically they are very steadfastly in support of the ACO model for moving forward, and did not seem to show any inclination to pause the DCEs. They did agree to meet with us again. We met with them just in the very end of 2021. That has not happened at this point. And we are, I'm gonna stop sharing. But now what we've seen, there's been a fair amount of media coverage. There was a Washington Post article. There's been a lot of coverage in left-wing media. I did give some of the organizers of the meeting some links. There was an excellent interview on the Ralph Nader show with Kip Sullivan, who's an attorney with the Healthcare for All Minnesota, I think, and he has very detailed understanding of how these ACO models work and the history of corporatization of Medicare. And I strongly suggest listening to that. And I don't know, Justin, where that's going to be available for participants here, but that's a great interview. So I'll stop there and see what kind of questions you have.
Excellent. Thank you so much, Dr. Albert. That was incredibly informative and incredibly scary at the same time. So now we're going to open it up to questions from everybody present, which will be answered by Dr. Albert and Dr. Marilyn Vaché, who is also on the call here. Dr. Marilyn Vaché is a psychiatrist in New London, Connecticut. She received her medical degree from University of Arizona, College of Medicine, Tucson, and has been in practice for more than 20 years. She's also the co-founder of this most recent revival of PNHP Connecticut and very much responsible for tonight's meeting. So we're very grateful for her being here and taking some questions along with Dr. Albert on this issue. So if you have a question and you are shy and don't want to come on video, you're more than welcome to put it in the chat and we will be sure to get it answered. You can also raise your hand if you know how to do that in the Zoom feature. If you don't know how to do either, just unmute yourself, and when there's a silence, give a little shout out. But I have fielded a couple of the questions here that were put in the chat. And one that we can start with is from Lori Diffenderfer about the oversight or lack of oversight by Congress on DCEs, and how is that possible? Do either of you know how that's possible?
I mean, it's possible because that's that's how it was written in the ACA. And when we brought that up to Liz Fowler, they kind of poo-pooed it and said, you know, we would never do anything unless, you know, whatever, there was support. So it just kind of hangs there. And you know, I don't have any other explanation as to how that or why that happened. I mean, I think politics is the answer. I mean, you know, right now what we're seeing is that the Biden administration seems to have no inclination to move on this. And as everybody is aware, the extreme partisanship is causing the people in Biden's party to, you know, toe that line. We spoke to a number of Congress people. Most of them, we spoke to their aides, which, you know, shows you something that they don't feel it's important enough to come even to a Zoom call to meet with people concerned about these issues. And they expressed that many of them did express surprise that this situation existed without oversight, but you know, nobody seemed to want to do anything about it.
Yeah, very sad. The next question or set of questions comes from Thomas Burr. Are the insurance companies involved in Medicare Advantage actually assuming any real risk? And is it true that Medicare Advantage is really only a good fit for people who are healthy? And then my question was sort of in the same field, is that how does Medicare Advantage recruit healthy patients?
Well, I'll start with that one first, the recruiting healthy patients. So, I mean, initially, some of the ways that they would recruit healthy patients would be to offer some sort of free presentation or lunch or something like that. And if you could show up, they would try to get you signed up. And so, you know, this was a proxy to recruit people that were able-bodied, had transportation, were probably reasonably healthy. So that's one example of how that may have happened. As to are insurance companies bearing any risk? Yeah, I mean, the whole reason why they want to they want to use the risk score system is the higher the risk score for the beneficiary that they're going to get paid up front before anybody gets sick, then, you know, the more they'll get to keep if the claims don't get paid out. So they're, you know, they are exposed to a certain amount of risk, but it doesn't seem to be hurting their bottom line. I'm sure people are aware of the profit statements of, for instance, I think United had, you know, tens of billions. And, you know, you just look at what happened in 2020. They were already paid, you know, whether you're talking about private employer-driven health insurance or Medicare Advantage, all the premiums were paid and nobody was getting health care because they were too afraid to go to the hospital. Elective procedures were canceled and so forth, and they got to keep all of that. And within the ACA, there is something called a medical loss ratio, which means that it's an 85%, 15%, which means that insurance companies, and this applies to Medicare Advantage as well, have to spend 85% of the premiums, or what they're paid by CMS. Premiums would be, you know, your individual premiums if you're getting insurance through your company that you work for. 85% has to be used on clinical care, but anything left over, 15% of it is theirs to keep. And when you're enrolling millions of people, that's a lot of money. Now, I can't remember what the other question was regarding insurance.
Before you do that, I'd like to just add in with the DCEs, the risk ratio is 40%.
Right.
If they can keep up to 40% of the money they get from premiums and from our tax dollars.
And that with traditional Medicare, it's currently 96 cents on the dollar that is spent on actual healthcare costs, and only 4 cents is on administrative, which is very good. And then, as you said, it was 85 and 15 on Medicare Advantage, and now with DCEs, it will go down to 60 cents on the dollar being spent on healthcare and 40% being kept on profits. So everybody here at some point will be on Medicare, and your healthcare will go down to 60 cents on the dollar. Let's move on. Our next question comes from Rana Stuller. And what are the implications of DCE's impact on the viability of Medicare in the long term?
I mean, I think that the implication is that the Medicare fund will be depleted more quickly. And what that seems to lead to is full-on corporatization of healthcare. Like, the private sector can always do it better. And so, yeah, that's the reason why we are upset about that, DCEs. Because the more they weasel their way in, the harder it's going to be to ever shift to a single payer system.
Okay, great. The next question is basically, am I or a loved one currently enrolled in a DCE, and how can I check that out? And how can I opt out if I want to, or even can I opt out?
I can answer for Connecticut. There are 2 entities contracted in Connecticut, but the last time I checked, a couple weeks ago, no provider groups had signed up in Connecticut with those organizations. So we're still on the cusp before this moves into Connecticut, but it could happen any day. I don't think opt-out is really possible unless you change your primary care practitioner. Otherwise, you're enrolled.
That's my understanding too. And I mean, we have seen in some states where it seems like the direct contracting entity that has made the most inroads is Clover. And we've seen some letters that beneficiaries have received. Like I said, they don't say direct contracting entity. They just say, you know, your doctor has asked us to help them with your care. And I don't believe that the letter gave any indication about how you could opt out.
Yeah, so that's incredibly frustrating because opponents of Medicare for All, for instance, you know, saying how we have choice and freedom of choice, and you know, this is America, and you not only do you not have choice, you don't even know that you've been rolled in this sometimes. So that is unfortunate. There was one additional question on how can we find out which Congress people have signed onto the letter regarding DCEs. For example, did this person's representative Jahana Hayes sign it? Because she is also a co-sponsor of Medicare for All.
I don't have that list in front of me. I can probably get it to you. I've seen it somewhere, sent in an email. There's 54, but I don't know your Connecticut reps that well. I know only one Western PA rep signed.
Well, I happen to know, and Justin Paglino has also put this into the chat. Here is a copy of the letter.
Perfect.
Right there. And actually, Jahana Hayes did not sign it. I think they didn't get her in time. However, and shockingly, Rosa DeLauro did sign it, so that's very promising for us. And Jim Larson did as well. So that's very promising that those two sort of centrist representatives who also accept healthcare industry financing sign those as well. There are just a couple more questions here. Sorry, do the primary care doctors, sorry, the question keeps, do the primary care doctors have to share with specialists, and would the direct contracting cover all the testing and hospitalizations you might require?
You know, I believe that you would, you know, if the direct contracting entity did not employ specialists, that they would contract with somehow, and would they cover the testing? Yeah, I mean, I think they would, but the advantage that they might have would be in some sort of narrow network situation, that they can get lower fees from those other providers. But again, we're just not really able to see it happening in real time because it's just getting off the ground.
Right. Okay, and one last question from the audience, and then we'll go to Justin. But what are the two DCE entities in Connecticut?
I have misplaced their names. I apologize. I think one is called Iris, and I'll have to look up the other.
Okay, and if we will also have the full answers to all of these questions. If there's any additional information that we will include in our follow-up email. So please be sure to sign up to our newsletter to get that. And Justin Paglino, you had a question?
Yeah, I guess I have a question about to what degree do we feel like the horse is out of the barn? I get a feeling like that, you know, the DCEs are already signing contracts with HHS, and what are the duration of these contracts? They call it a pilot program, but it seems like they're, you know, this is kind of happening in real time. But I get the my understanding is that HHS still has the the authority or the capacity to end this, correct? And to transfer the enrollees back into traditional Medicare. I mean, my understanding is that of the 36 million people enrolled in traditional Medicare, up to 30 million are potentially in the line of fire, so to speak, or are in their sights for getting enrolled into a DCE program. But my understanding, and I just want you to confirm this, is that this is reversible at this point. Is that correct?
I mean, that's my understanding also, mostly because they're pilot projects. And I think that I think it is a 2-year situation.
Wow.
And that the other thing that, you know, we were told is they paused the enrollment at the 53 or so that they took, but as of this year, they're going to start taking applications. One of the things that Liz Fowler and her attorney said, the CMMI people said, is that they were worried about legal action being taken against them because there were DCEs that didn't have the chance to apply, or, you know, were discriminated against, or some nonsense like that. So, you know, yes, that sounds to me like, you know, the door is open. And you know, again, I think the fact that you're seeing pushback at high levels, you know, articles, there have been a couple articles published in Health Affairs by people who were trying to correct the misinformation that PNHP was providing, and so on and so forth. And that suggests that, you know, the high level people are a little bit worried about what we might be doing. And that means that we need a groundswell of grassroots organizing to keep the drumbeat going.
Yes.
What a perfect segue, because we are
Yes,
now
good
going
segue.
to be talking about what we can do, because I, for one, am appalled by this. I am incredibly frustrated, and I'm not even on Medicare yet. So I think what we will be doing now is actually going into breakout rooms to talk about what we can do about this, because it will take each and every single one of us here, plus everybody's networks, to be able to stop this. So we are going to go into breakout rooms. You will have the option of which breakout room you'd like to go to based on which action you'd like to take. So group 1 is letters to the editors and writing op-eds to inform the public as much as possible about this, and that'll be led by Justin Paglino. Group 2 is brainstorming partner organizations and mobilization. So we'll think of which groups we can get involved with to mobilize their members as well. That'll be led by Holly. Then group 3 will be phone banking the public, and that'll be led by me, and we'll talk about questions and ideas and script things that we will talk about when calling the public to get them into action. And lastly, group 4 will be on calling and writing to our legislators here in Connecticut, as well as CMS and Liz Fowler, to get them to take action on this and to express our concerns as well. So I'm going to pass it over now to Amanda, who is one of our co-chairs of our communications committee and responsible for all of our wonderful logos and branding, to just explain the process of the breakout rooms.
Hi, everyone. So, Savon,
Amanda, are you able to?
Oh, sorry. I'm gonna stop recording if that's all right, because I believe after the breakout rooms, everything should be okay, so.
Group was the phone. My group was the phone banking group, and Dr. Vaché kindly agreed to report back.
All right, Dr. Risi and Sivan and I met and came up with the beginnings of a phone banking script. Dr. Risi will refine it and send it to us, and then we will make it available to everybody. And we hope to get the phone banking started within a few weeks. There's no deadline, but the point is to get it to call a lot of people and get a lot of signatures.
Yes, so please be on the lookout for our phone banking events, which is open to everybody in and out of state as well to sign on. We always have a training before, so if you've never done it before, do not be afraid. It is very easy, and then we will jump into the phone banking and also have a discussion of how it went as well. Why don't we go to group one, which was Justin Paglino's group?
Hi, yeah, we I shared the links for the petitions to get everyone to sign those, and we talked about letters to the editor and how this is an issue that we just need a groundswell of word of mouth. So letters to the editor are really something that are effective, and you just find your local paper, find out how to submit, how many words they want, and we have, once people hear about this and kind of understand what it is, I think it resonates with people. But in your letter, you can kind of communicate what the issue is, but also ask people to continue the chain reaction and spread the word themselves, and direct people towards sites like pnhp.org, where they can get more information and spread that information. And letters to the editor are one powerful way of doing that. So we talked about that.
Fantastic. Okay, and group three was partner organizations with Holly.
Okay, well, I discussed with Tom and Dee, who, by the way, Dee is from Span, Ohio. Thanks for coming. We have had you guys come present to us before. You're a great organization. So thank you for your input as well. We discussed how when we are partnering with an organization, we have to make sure that we have clear-cut guidelines of what the ask is, of what we want people to do. But first, we need to make sure that we educate them on exactly why they need to fight the DCEs and exactly what they can do, but we need to be clear as to what the ask is. So, obviously we know that people who are retirees are on Medicare, but a lot of times people in the disability community are forgotten about. We too are on Medicare. So we talked about that, and Tom suggested contacting Disability Rights Connecticut. I have not done that yet for the DCE situation. Connecticut Cross Disability Lifespan Alliance, they are on my list of organizations to connect with, but I have not yet. So there were definitely a few discussed that I had not had on my radar, but and Tom had suggested that, when you are going to do some advocacy work like this, that maybe partner with an organization that's already well established, like a NAMI, which is National Alliance on Mental Illness, so that they can help you maybe bridge that networking connection. So that was a really good piece of advice as well for partnering with other networking people, organizations. Thankfully, I kind of do that. So yeah, it was productive. Yes.
Excellent. Sounds really good. And group 4 was contacting legislators with Justin Halloran.
Yep. So we had about 5 people in our group. We were kind of discussing, I think, some of the big asks that we're looking for when speaking with legislators, specifically when reaching out to Congress people, making sure that we're kind of discussing the lack of congressional oversight and having them sign on to Jayapal's letter. Also trying to keep legislators who have already signed on, like Rosa DeLauro, engaged, and making sure that we're also following those leads to make sure they're actually feeling incentivized to continue that fight. I have a few resources I'm going to ask you to spread out, Sivan, after the meeting, just with contact information so that people can be reaching out to the appropriate people, as well as a template letter that Justin Paglino provided from another advocate who sent it to us. So we can try and modify that and make sure that it's pretty easy for everyone to use. I think you might be muted, Sivan.
Sorry. So that sounds really great, Justin. And so I just want to, on behalf of Medicare for All Connecticut and PNHP Connecticut, thank everybody for joining us, and a very special thanks to Dr. Albert for that wonderful and scary presentation. We will include all of the links, all the information that was presented tonight in our follow-up emails. So please be sure to sign up for our newsletter. You can find us on at medicareforallct.org, and you can sign up there. You can find us on social media as well. Please also sign up for PNHP Connecticut, and we will very much look forward to seeing everybody, see you in the newspapers, hear you on phone banks, and see you at all of our actions and activities that we have around this to make sure that we stop this in its tracks. Okay, so thank you again, everyone. Have a wonderful evening, and we will see everyone next month for our next monthly member meeting.
Good night, everyone. Thank you all
Thank
so
you,
much.
Thank you,
everyone.
everyone.
Thank you. Good night.